Everybody knows what it is. Everybody likes to do it. So that's kind of why we're doing it. The definition of our problem is that we have lack of compliance with the hospital policy, which is 100% bedside shift report. Every patient, every shift. We have an inconsistent procedure with it. Part of that just ends up being because each nurse who's given a report values different information than the one who might be receiving it, so it seems to be kind of time consuming. What is bedside shift report? The definition of it is that bedside exchange of vital information, responsibility, and accountability for patients between the offgoing and oncoming nurse that ensures safety, continuity of care, and delivery of best clinical practice. It pretty much sums it up. So why does it matter? Part of it is the patient safety and satisfaction scores that we get. They're the pay for performance here at Cabrini. So we have some HCAP scores for January 2019 that was reported in February, with the overall hospital satisfaction being 65.3, but FCMC was only 60, so we were lower than the entire hospital. And I think as part of our patient population, what we do here is that we should be higher than that. Like, we should be making these patients happy. They're having babies and taking them home. Most of those complaints were related to lack of attention to personal needs, slow or no response to any complaints that were given, slow to help to the bathroom, lack of respect or courtesy, cleanliness of the room, staff not washing their hands before examining patients, and lack of explaining procedures in a way that patients understand. The responsiveness specifically on that HCAP score for FCMC was 55.8%, which was pretty low. So, and that's slow response to call bells, questions or concerns not being addressed, and not getting them help to the bathroom. Our scores did increase in February to 86% on that, which is really good. 65% is what a good score is. So why does it matter? It makes patients feel important. It reduces the time patients go without seeing a nurse, decreases feelings of neglect, reduces risks of falls and harms. You get to discuss the plan of care with them, and what goals you're going to have for the shift. And patients' pain is better managed because you're in there talking to them, and they're not going to be talking to you about their plan of care if they're in pain. They're going to let you know that. It also helps with nurse accountability. So when you are going in that room with the other nurse, you're looking around and you're leaving, so you need to take the peanut balls out if the patient's already delivered, and the IV poles and all that. You can check with the patient on how their pain is being managed. Number one complaint by our patients is that their pain is going unmanaged, or they don't know when their next dose of medication is. IV site care, you look at that, make sure it's patent, it's going. Does the baby have a hugs tag on? Is it put into the system? And is the whiteboard updated? How long should it take? The research says 3 to 5 minutes per patient. Now, some of us are long talkers, and the patients are going to be talking to us and stuff too, but it seems to be, according to and I've kind of tested this out a little bit just on my own. Whenever you're in the room, there's less distractions from what's going on out at the nurse's station, people talking to you. It keeps the focus where it's supposed to be, which is on the patient. And like I said, the research does show that it reduces that overall time. What I did find in the research is with the times that it did take longer than 3 to 5 minutes, it was usually related to a patient safety issue, and nurses didn't mind it taking so long because they were able to find an issue and fix it before it got too bad. So things that you talk about during bedside shift report on an adult, with all of our patients, we need to be introducing ourselves and then managing up the next nurse that's coming. It doesn't mean you have to make up stuff about her, but let that patient know that you're leaving her in good hands. So talk about the situation. This is our S-bar that we've been pounded into us. We should all know this. What's their diagnosis? Why are they here? So they're a triage. What's their complaint? If they're an antepartum, what's going on with them? Were they in labor, or are they postpartum? Give a little background on them. It's a brief description of their current condition, their G's and P's, their due date, their medical surgical history, what type of delivery they had, allergies, blood type, labs that you've already done. And then what's the assessment? Are their vitals within normal limits, or have they been abnormal? What's their hemorrhage risk? What's their pain rating? When's the last time they had pain medicine? Look at their wounds, look at their perineum, look at their abdomen, if they've got anything else going on. Their IV access, what current medications are they on, especially if it's out of the ordinary medications that they're taking. And do they have a Foley catheter? We need to be looking at that. And what's their quantitative blood loss? And then whatever recommendations there's going to be, what's pending labs, what procedures they're going to have, treatments, any testing, discharge planning, their immunizations, and then the shift plan of care. And when we talk about newborns, we want to say this S-bar is the same thing. They were born, so that's their situation. They're here. their background, so are they okay, what type of delivery it was, which you already kind of assessed that with the moms, their blood type, their admit labs, did they get their eyes and thighs, and then the assessments, or anything abnormal, what about their pain, do they cry a lot, does it seem like they've gotten hurt during delivery, did they have a circumcision, so wounds for that, do they have an IV access, what's going on with that, current medications, talk about their feeds, what type, the tolerance, what time they ate last, eyes and nose, are they peeing and pooping, and their daily weights, bath, and are they banded. And then the recommendations, if they're having any labs, are they going to have their CCHD, their newborn screen, those types of things, and then plan of care and discharge planning. So the unit goal is bedside shift report completed on every patient on every shift. End of story. So the plan for evaluation, this is going to be validated because we're going to be doing this 100%, right? Validation is going to be done by the nurse leaders, which is the unit manager Pam and our charge nurses, mainly on patient rounding. Patients love to complain. We all know that. So when they go around and if someone asks them, did the nurses do bedside shift report? They're gonna say it. They're gonna tell them. And then with the badge tracking, as well as chart audits. So there are going to be 5 to 10 charts that are audited weekly on that. Looking for the documentation of the bedside shift report intervention, which is I tried to get some stats from Danae. She said that it's really low. That's all she said. It was really low. But whenever we are doing that intervention, that's a timestamp. And so if the badge tracker happens to be pulled to see that it was done, but you were nowhere near that room, then that's going to be an issue. So in conclusion, people tend to evaluate an experience by its ending. Even if a shift starts out terrible for even us as nurses or for the patient, you can work on it being good toward the end, and then when you leave and clock out, you're in a much better mood than you were when you probably started. You want to take the opportunity you want to thank the patient for the opportunity to share their experience with them. This should be a super happy place. We know it's not always, but it should always have a level of happiness that's here, and it'll help you end your shift on a positive note too. Okay? Any questions? Thank y'all.